in Egypt and Gulf area. Good afternoon, Professor Philip. It's our pleasure on behalf of EMOG Group. We are delighted to start our fourth event that will be about neuroendocrine tumor, new therapies and updates that will be presented by Professor Philip, which is a worldwide figure of neuroendocrine tumor, Professor of Oncology, Karmanos Cancer Center, Wayne State University, Detroit, Michigan, USA. And the presentation and the floor will be moderated by our great professor, our friend, Professor Muhammad Yassin, Professor of Clinical Oncology, Ain Shams University. So the floor for you, Dr. Muhammad.
Good evening, my dear colleagues. And I would like to thank all my dear colleagues for inviting me to moderate this great session. And it is a great honor for me to introduce a great professor, Professor Philippe Agoub, to give us his insight on neuroendocrine tumors. And Professor Dr. Philippe is a Catherine Kramer, MD, Endowed Chair in Cancer Research and is the leader of the gastrointestinal and neuroendocrine multidisciplinary team at the Barbara and Karmanos Cancer Institute in Detroit. He also serves as Professor of Oncology and Pharmacology at Wayne State University School of Medicine. And his biography is, we need a lot of time to introduce Professor Philippe Agoub. And for me personally, I have attended one session for Professor Philippe Agoub. He was talking about pancreatic tumors. He's specialized and he's a great scientist. He goes deep into the biology and genomic behavior of tumors, especially microenvironment and genetic alterations. So it is a great honor for me. And for me, he is more a scientist than being a physician. So I think we will learn today many aspects of pancreatic neuroendocrine tumors. Please, Professor Philippe Agoub. Yes, thank you.
Thank you very much, Professor Mohammed, for this very kind introduction. I'm privileged and honored to be with you. And please remember also, all of you, that I'm a graduate of the University of Baghdad.
Okay,
and I'm an Arab.
So yes.
And I speak Arabic is my second language. I speak very fluently.
Sure, Professor Philippe.
Okay. So I'm going to start. I think we're ready, right, now to start?
Yes.
Yeah.
Yes.
So what I'm going to do is I'm going to talk about neuroendocrine tumors, and I'm going to talk about new therapies and some diagnostics. But the important point I want to make is that worldwide we're seeing more of these patients, and this is something very important because as not only oncologists, but different aspects of medicine are involved with this disease. So I really want to make sure that all of you are aware of what's going on, but also because it touches all specialties, believe it or not. I mean, you will see what I'm talking about. So I just want to start with one example.
So this is the best way that I can think of to study this.
Hello?
Here's the slide.
Okay, so basically, I think there's some interference somewhere. So let me just go back. So what I'm trying to say here is that if we see a patient, for example, this patient who came to me with multiple metastases in the liver, and if this same patient sees several other specialists, everyone is going to give a different opinion on the patient. So if they see a surgeon, if they see an oncologist or endocrinologist, really they will end up with different opinions. And this is the reason why I think it becomes very important for us to know more. So because one doctor might recommend doing liver-directed therapy. I'm having some problem with the slide, so I apologize. Some doctor might recommend watchful waiting, or someone might recommend just like Octreotide treatment on a monthly injection. So one of the key things is that you can see here that we are seeing an increase in the incidence of this disease. And it's really very rapid increasing. You can see here, if I can show you with my pointer. So there is a rapid increase. And also the prevalence of the disease, which is increasing also. So we're seeing more people around with these diagnoses. So this is something which really has to be well known, because you are going to see more patients with neuroendocrine tumors. And one of the reasons why we're seeing more patients is that we not infrequently diagnose these patients when you're doing a scan for something else. For example, if a patient comes to you and you're looking for, let's say you're looking for even like a pain in the right upper quadrant, you're doing ultrasound, you may end up seeing some liver metastases. Or someone comes to you with renal colic and you do a CAT scan to rule out a stone, and you find something in the pancreas, or you see something in the liver. So we also are diagnosing people this way a lot. Unfortunately, because of the nature of the disease, most of the patients we diagnose have advanced disease. Now, if we look at the proportion of patients we see in the GI tract who have neuroendocrine tumors, you can see that, or in general, compared to other sites, the majority of the neuroendocrine tumors come from the digestive system, the GI tract. And within the GI tract, you can see that it spreads around. The jejunum ileum is probably one of the very common sites, although the rectum also will have some tumors. And then there are fewer other areas that we see, like the appendix. And then the long neuroendocrine tumors. And also there might be patients who come to us with liver metastases, and we don't know where the neuroendocrine tumor came from. So just to give you an idea of where these things are coming from. Let me just focus a bit on the GEP-NETs, which are the gastro-enteropancreatic neuroendocrine tumors, and because these are the most common ones. So the annual incidence in America is like 5 cases per 100,000. And over the last 30 years, there was a 500% increase in the incidence over the last 30 years. So this is really more than any other cancer. And I don't think that there is something in the environment that increases the incidence of this disease. I just think that we're more aware of it and diagnosing it more. And that's really the most important thing. And if you look at the most prevalent GI malignancy, the most you see in patients coming to the clinics, not only the newly diagnosed, but patients coming to the clinic, actually it's more prevalent than a number of cancers that you know of: pancreatic adenocarcinoma, stomach adenocarcinoma. In fact, it's the second to colon cancer. So that makes the gastrointestinal pancreatic neuroendocrine tumors an important disease. And I have a large practice myself, and I see a lot of those patients. They come referred to me in Michigan. I have the largest practice of it in Michigan. Let me tell you a few words about pancreatic neuroendocrine tumors. These are also special tumors. They're not common, but still the incidence is increasing. And they represent less than 5% of the pancreatic cancers. And they can be either sporadic or associated with certain genetic syndromes. And the most important ones are MEN1, VHL, NF, neurofibromatosis, tuberous sclerosis syndrome. And they have, generally speaking, better prognosis than pancreatic adenocarcinoma. So just to give an example, the average survival of adenocarcinoma is maybe 1 year, 2 years, or less a lot of times. In those tumors, people survive several years. And Steve Jobs, who had Apple, as you well know, he did have a pancreatic neuroendocrine tumor, and he survived, I'm not sure, 5-6 years. That's not typical of adenocarcinoma. Now, the other thing is that those are, the neuroendocrine tumors are also important because they secrete a number of chemicals or hormones. The one that you know of very well is the 5-HIAA, but they also do and you measure it in the urine or serum, but you can have others. gastrin, insulin, glucagon, vasoactive peptide, VIP, and few others. And the point here to make is that they can secrete those. You can see them in the blood, but not always they will be associated with a clinical syndrome. So for example, you may see the insulin levels going up or the gastrin levels going up, but it doesn't mean that the gastrin level going up will produce necessarily the symptoms of a gastrinoma. Or as insulin going up will produce like hypoglycemia. If it does, we call the patient has functional tumor. And if there's no clinical syndrome, then we don't call them being functional, despite the fact that biochemically it may be elevated. So if we look at the pancreatic neuroendocrine tumors, and as you know, the older name for it is the islet cell tumors. We don't use the expression islet cell anymore. We call them pancreatic neuroendocrine tumors. And the non-functional ones, it depends who writes the articles. Could be 40% or 90%. In my own experience as a medical oncologist, it's really less than 30% or even 20%, especially nowadays, because remember, nowadays we discover those tumors more when they are asymptomatic just by doing a scan for something else. So there's more and more. So the new literature, I don't know how much it really goes into that, but from my experience in the last 10, 15 years, you don't really see much in the way of people come to you diagnosed with insulinoma or glucagonoma, but you see many more patients coming with like a pancreatic mass. The functional tumors, the most common one is insulinoma, which causes the hypoglycemia. Then you have glucagonomas, gastrinomas, somatostatinomas, lipomas, etc. And these can be very rare. So I'm just giving you a bit of a picture of the clinical situation. Again, I just want to go back to something which is the genetic syndromes, because these can run in families, and MEN1 you're familiar with, the von Hippel-Lindau syndrome, also tuberous sclerosis complex, and neurofibromatosis. So these are genetic syndromes which would include pancreatic neuroendocrine tumors, but not only pancreatic, it could be other tumors, as you well know. Now, what are the symptoms? Now, a number of these symptoms that we see in patients with neuroendocrine tumors are, we call them non-specific. Like they can have some abdominal discomfort, abdominal pain, loose bowel movements, diarrhea. And I have a lot of patients who, in my practice, who were diagnosed with inflammatory bowel disease, but most often irritable bowel syndrome for a number of years before someone figured out or decided to do more testing, and they were found to have a carcinoid syndrome. Again, someone with bronchoconstriction can be confused for asthma and flushing, but the diarrhea is really the most common symptom we see. But then again, you really have to go through a differential diagnosis, because with diarrhea, as I said, it could be, it may not be carcinoid, it could be truly an IBS, but we don't know. Flushing in someone, a lady who is 45, 50, it could be menopausal. The flushing from Carcinoid syndrome is a dry flushing, whereas with menopausal symptoms, it's more like sweat. So there's sweat with it. It's wet flushing. The diarrhea with neuroendocrine tumors is also could be very watery, could be urgent, and it can also wake them up at night. So this is why I think if you go back to your practices, you may see that you always had some difficulty in some patients. But there's something which when you think about this disease, there's one thing which I don't encourage you to do, and I'm going to come back to it in a few minutes. So the answer here is that there's a lot of people who really end up with months and sometimes years before they get diagnosed. And this is just to give you an idea that a proportion of patients, like in fact, if you look at here, the mean number of months from the onset of the symptoms to diagnosis can really be several years. And this is obviously what we see. And is there a way we can improve it? Obviously, we can improve it by having a different algorithm or a better algorithm in going over symptoms when patients come to you either as a family practice, internist, surgeon, or if you are an endocrinologist, gastroenterologist, there might be some better way of trying to figure out the diagnosis earlier. Again, this goes back to what I told you. There are various diagnoses that people receive: inflammatory bowel, irritable bowel syndrome, gastritis, and all sorts of things before the menopause, before they come into a real diagnosis. And again, in some ways, it's interesting, challenging, but for patients, they can go backwards and forwards for multiple times to see their doctors and nothing happens. The other thing about this disease is that if you look at this CAT scan, and if you look at it, you see that there are a lot of lesions in the liver, for example. And believe it or not, this patient didn't have as much symptoms. So if this patient had real, let's say, pancreatic adenocarcinoma, or if the patient had colon cancer with liver metastases, with the amount of disease they have, they tend to be sick. In patients with neuroendocrine tumors, they tend to be relatively less sick than patients who have adenocarcinoma. So if you're sitting in a tumor board and someone says, or if you're in the clinic and someone refers you a patient, and you look at the patient, you do the scans, and has a lot of disease, but otherwise the patient doesn't look that bad, the chances are the patient has a neuroendocrine tumor, not an adenocarcinoma. Now, apart from stage, which is always we use in cancer, the other thing which is important in prognosis of patients is the degree of differentiation of the tumor. So well-differentiated tumors do better than moderately differentiated tumors, and poorly differentiated tumors do the worst, as you would expect. But you can see here is that in well-differentiated tumors, if you look at the median survival, it really is still a fair long number of months or years. And unless they have the intermediate grade, which is here, or the poor differentiated. So basically, you really are dealing with disease that if it's a well-differentiated, well-behaved, even if it's metastatic, which most of the time it is, or locally advanced, patients can still live for a long time. Now, the other thing, apart from the morphology, which is well-differentiated, poor differentiated, the other thing which is important in terms of the prognosis, which is very important, I use it a lot, and it's really very important, is the Ki-67 index, proliferation index. And this separates the tumors into grade 1, grade 2, and grade 3. So this is grade 1, well-differentiated, intermediate grade, and then this is poorly differentiated, high grade. And the index separates the three, and the mitotic count also helps. We use probably the Ki-67 much more than we use the mitotic index. And why is this important for you? Because first of all, it helps you to decide on the newly diagnosed patient, how do you think they're going to really behave their cancer? But the second important point here is that if you don't have the information, you can't do that. And therefore, your pathologist in the hospital has to really be good and well-trained to really give you these numbers, the Ki-67. And for a disease that's not common, sometimes even in the United States, we see reports coming to us and they don't have the Ki-67. The pathologist didn't feel that they need to do it. So this is something very important. Now, in 2017, the WHO did a change to the way we look at pancreatic neuroendocrine tumors. So what we have here is that, so the grade 3 here, this one, used to be put under here. Now they said that, well, these patients look like they have well-differentiated tumors. It's just they have a high Ki-67 and mitotic index. And therefore, what they did was, because these patients behaved more like well-differentiated than poorly differentiated, they put it as part of the as they made a grade 3 for this. And then here, this stays obviously the same. These are poorly differentiated. So these patients here at the bottom are the ones that are really looking bad. They have a very aggressive disease. And these are patients who behave like small cell lung cancer. aggressive, rapidly proliferating, and all that. Now, there's another thing which is really important, is that nowadays with the newer science that we have, the basic science, molecular profiling, genomics, now we can even look at a better way of trying to really separate between people who do well, the well-differentiated, and people who do poorly, the poorly differentiated. Remember here, I told you this is the bad group. So the things that we do, these are the things we do. For example, the DAX and the ATRAX is seen in well-differentiated, not seen in poorly differentiated. The poorly differentiated have like RB, P53, KRAS. So the poorly differentiated is a bit like even small cell, and also like the common variety pancreatic adenocarcinoma. But the most important thing for you to realize is that the DAX, ATRAX, and also the MEN1, which I didn't put here, these are more for the well-differentiated tumors. So because I am I'm the medical oncologist who I get cases referred to me from around Michigan, I also have a challenge, a problem. So my problem is that I see patients who go to see like an internist or a family doctor or gastroenterologist or even an oncologist in the community, and they're suspected of having Carcinoid Syndrome. And what they do is that they do Chromogranin A testing, and the Chromogranin A level comes back as elevated, which is a problem because Chromogranin A can be elevated not only from Carcinoid Syndrome or carcinoid tumors, but from other things also. So please don't use the Chromogranin A as a diagnostic tool because that can confuse you. And not only that, because then you will tell the patient, I don't know what you have. You may be having Carcinoid Syndrome or tumor, I don't know. And the patient becomes very anxious. And they start to go from one doctor to another, and nothing is found that they have a tumor. It's only because it's elevated because of this. So it's non-specific. Benign conditions. One of the most important things we see in patients who have been taking proton pump inhibitors, it really can push the levels up. But a number of other benign conditions can do that. And even other cancers can do it. So I wouldn't use Chromogranin. It's like you don't use CEA to diagnose cancer. You diagnose the cancer, then you do the CEA to help you monitor the disease. And the same thing is with this one. So that's really very important to know. However, if you have a patient who has the neuroendocrine tumor, you can use the Chromogranin A level going up and down to understand how the disease is doing. But again, not to diagnose the cancer. So now I just want to go over some of the treatments we have for this disease. In patients who have the mid-gut primary, which is the commonest, we have the somatostatin analogs, octreotide, lanreotide. We'll come to those. We have everolimus, interferon that we really don't use anymore. And then we have a new treatment called PRRT. In pancreatic neuroendocrine tumors, we have a longer list of potential options, which is interesting because in pancreatic neuroendocrine tumors, we have more options than the gut, like small bowel or appendiceal or rectal neuroendocrine tumors. So I just want to really take a minute here and just give you a bit of another look at the molecular level of these tumors. So the neuroendocrine tumor cell is, think of this as the neuroendocrine tumor cell. It has receptors. You can see those receptors. They're called somatostatin receptors, SST, somatostatin receptors. And the somatostatin receptors are present in the majority of the neuroendocrine tumors, especially those who are well differentiated. So somatostatin receptors present on the tumor cells, especially the ones that are well differentiated, not the poorly differentiated that we talked about. So what can we do with that? Well, there are a couple of things we do, but the principle is the same. So if you have this receptor here, and normally there's something that binds to the receptor, correct? There's something that binds to the receptor. Could be a growth factor, whatever. So what you really do is you take your growth factor, we call it somatostatin analog. So think of it, this is the analog. This is going to be binding, this bit is going to bind to the receptor. And then the molecule will have either a reporting unit, which is to do imaging, nuclear medicine, or a cytotoxic unit to use it for treatment to kill the cancer cells. And then in between, you have other things which make the molecule work. So if you if you look at the somatostatin receptor, you can use those receptors either for imaging, nuclear medicine, or you can use it for targeting with treatment that can kill those cells. I hope that makes it easier on you to understand. So the most recent scan, so when I was a medical student and even like 4 or 5 years ago, in our hospital, we used to use something called Octreotide scan or Octreoscan. It was a nuclear medicine scan spec using, now this one is different. The new one is called gallium-68 dotatate PET. It's a PET scan. It was approved in the United States in 2016. Now we use it routinely. It is much more sensitive than Octreotide scan. And obviously, it's a better scan than doing a CAT scan or MRI to see the whole extent of the disease. It also can see disease in the bone. So bone spread is common in this cancer, and this scan can see it. And so we use this as a routine. Why do we use the dotatate scan? We can use it for staging the disease, but we can also use it to see whether, based on the uptake of the gallium-68, how many receptors there are on the tumor cells. So the more there is uptake, the more receptors, meaning that you can probably treat them better with somatostatin analogs. So if you look at breast cancer, you do ER/PR status by expression, immunostaining. Here, you're doing your ER/PR status by using nuclear medicine. How intense it is taken up there is really telling you how much of the receptor there is there. And the more there is receptor, the better your response to treatment will be. Again, making an analogous description with the ER/PR. This is just to tell you that there are several molecules that you call them somatostatin analogs. I just don't want to spend more time. I think this could be easily. So how do we treat those patients? So remember, most of the patients will have the somatostatin receptors, can target the somatostatin receptor. And one drug is octreotide long-acting LAR. And this is the same as sandostatin. And this is a study that was done many years ago. And it shows that in patients who received octreotide, their disease took longer to progress, although survival wasn't that much different. But progression-free survival was improved over placebo. So patients did better. There was a more recent trial, when I say recent, like in the last 10 years, looking at another drug called lanreotide, which is given every 4 weeks also. And this trial also showed that there is a delay in the worsening of the disease. So we have two drugs, octreotide and lanreotide, we use in the management of this disease, especially in patients who have the well-differentiated tumors, patients who really have, they don't have disease that's really rapidly progressing or getting worse. So, so basically, we do have a good, I mean, that's how we do it. Another thing about these drugs is that they can cause some side effects, but usually they are very well tolerated. They can give you diarrhea, possible. Believe it or not, you're using it to treat diarrhea, but they can also give you diarrhea. But the mechanism is different. The mechanism is different because the diarrhea that is a result of giving octreotide or lanreotide is because these drugs can reduce the secretion of the pancreatic juice, therefore less phospholipase, therefore less digestion of the fatty food, and therefore you can get steatorrhea. That's how you get the diarrhea with these as a side effect. And you can get the other thing which is important is that it can give you gallstone disease, and therefore the surgeons, whenever they're in those patients, they always remove the gallbladder, because if we use these drugs, we may end up with gallstones. You can also get hyperglycemia as a complication of these drugs. Otherwise, they're really very well tolerated. Now, the other treatment that targets the somatostatin receptor is the peptide receptor radionuclide therapy, or PRRT. And this treatment was a good step forward. This was approved by the FDA in 2018, in the early part of in January 2018. In America, we didn't have it. It was in Europe for 10 years. We used to send patients from America to Europe to get the treatment. So the PRRT is the same principle. You have the peptide, which is the growth factor, which goes to the target, which is here the somatostatin receptor, and the peptide is attached to a radionuclide, and the radionuclide can be any of the yttrium, indium, or it could be lutetium. But the one we use in America in approval FDA is the one with the lutetium. So the lutetium-177 dotatate, this was a study that was published in the presented in ESMO in 2015 in Vienna, and it also was published in the New England Journal of Medicine. It was a phase 3 trial of 4 administrations of the drug every 8 weeks. So every 2 months they get an IV, and after 4 treatments within like 8 months it's done. And this was versus a Octreotide LAR 60 milligram. And this trial showed that there was a significant prolongation of the progression-free survival in patients who received the lutetium. So this was a great improvement. So you have another treatment now that targets those receptors that's now available. Now I'm sure it's available in the Middle East, in the countries, because this treatment has been approved at FDA a few years ago. What about side effects? So the way we give this treatment is that it can give you nausea and vomiting. But why do you get the nausea and vomiting? So this treatment can cause renal dysfunction, can cause renal injury, and for that reason we give with it amino acid infusion to really reduce the risk of the kidney injury. And when you do that, you give a 20 amino acids, you can get nausea and vomiting. You can get some abdominal discomfort, fatigue, and possible worsening carcinoid crisis. But there are some long-term side effects that are also for us of concern. And for example, bone marrow toxicity. And there is a possibility of myelodysplasia. I think it says less than 1%, but it may be that we see it more if we continue watching those patients for longer. The mature survival data, we don't have it yet, but certainly there's a trend for improved survival. Now, I just wanted to, the talk so far, I'm focusing more obviously on patients who have the well-differentiated tumors, patients who's just checking the time, well-differentiated tumors, whose tumors don't grow very fast maybe. But I got a question now. I got a question from my friend and colleague, Dr. Ashinaber, who's from Saudi Arabia. And his question is, what about surgery? So in the United States, I just want to go back. In the United States, we do debulking in patients who have well-differentiated tumors. So when I see a new patient and the patient has, let's say, mesenteric mass because of small bowel tumor, primary tumor, we do send them for surgery. And the surgeon will remove the mass, remove the small bowel segment, right hemicolectomy, and then they remove the mesenteric mass, even if they have liver metastases. And the reason why we do this is because with these treatments I told you so far, the treatments really do not produce a major shrinkage of the tumor. But these patients live long. So these are not patients who come to you with colon cancer with peritoneal metastases. These are patients who come to you with disease that they can live with it long, and at some point they will develop bowel obstruction maybe. So what you do is you remove the tumor to prevent that happening down the road. Also, these tumors can produce a lot of serotonin, which causes local fibrosis, vascular insufficiency. So in my practice, someone comes to me with mesenteric mass because you just the lymph nodes matted, and then you have the small bowel primary there. Even if you don't see it, we go in and we remove it. And then we start those treatments I just mentioned to you just now, the octreotide, lanreotide. So that's a very good question I was asked. In fact, even in patients who have pancreatic neuroendocrine tumors, and even in the other neuroendocrine tumors, if the liver we can debulk it, we also do debulking. And when you do the debulking of the liver, you don't really have to leave zero. It's not R0. Even if you leave 20% of the tumor behind, it's still acceptable, or 10%, because no treatment you have that can reduce the shrink of the tumor that much. So the science has now improved, and we have more targets to go after in the cancer cell, in the neuroendocrine tumor cell. Sorry, I just. So one other target we have is the AKT-mTOR pathway here. So you can see that this pathway, which is involved in proliferation and survival, and there's a drug that you can target this pathway, which is everolimus. And everolimus has gone into 2 clinical trials, and again you can see that it also can delay the progression of the disease. The problem with everolimus, the good thing about everolimus is that it is oral, but the downside of it is it has side effects. And one of the side effects is it can cause effect on the blood counts, but it can also cause mucositis, pain in the mouth, fatigue, and older patients don't tolerate it well. Another drug which is currently being tested is cabozantinib. Again, it's a pill, and you know cabozantinib used in other cancers like kidney cancer, and this is another promising agent that we're looking at as a new available drug down the road. So let me tell you something about the carcinoid syndrome. So as we said, not all patients have functional tumors. So not all patients come to us with any functional in the sense that they have diarrhea or flushing and all that. But when they have these symptoms, it can be very debilitating. And the carcinoid syndrome happens when the tumor is in the liver. It doesn't happen if there's no liver metastases, because the tumor that's sitting in the small bowel, for example, or in the colon or somewhere, and when it secretes the serotonin, it goes via the portal system into the liver, and the liver detoxifies it. It gets rid of the serotonin, metabolizes it. However, if you have tumor that's gone to the liver, it produces serotonin. It goes directly to the systemic circulation, and that's the time you will get carcinoid syndrome. But again, not every patient who has a tumor in the liver will get carcinoid syndrome. So this is really very important to know. This is an interesting slide, and let me go through it. So this slide combines biochemistry and pathology and clinical picture, and then treatment. Let's start from the beginning. So tryptophan is metabolized to 5-hydroxytryptophan, and then goes all the way to serotonin, which we talked about is a bad thing. We don't want it. And then metabolized into 5-HIAA in the urine that you can measure. The rate limiting step in this process is tryptophan hydroxylase here. Okay? Keep that in mind. We said that you have liver metastases, they secrete the serotonin, it goes through the blood, and what can it do? It can produce all these symptoms we talked about, flushing, diarrhea, but here I want to focus on the other bad side effects of serotonin, which is producing fibrosis. So patients who have carcinoid syndrome can have fibrosis, and if it's in the right-sided heart valves, it can cause tricuspid incompetence and pulmonary stenosis. But it can also cause, if you leave the tumor, if you don't, again, back to Dr. Schneber's question, if you leave the tumor in the abdomen for a long time, it will also secrete locally serotonin that will cause fibrosis and intestinal obstruction. So in patients who have the carcinoid syndrome, we do check their heart once a year by echo to see whether they're developing that. And people can die, not all they can die of the heart disease rather than die of the cancer itself, believe it or not. So why did I put this whole thing together? Because now there's another drug. So we use the somatostatin analogs, as you know, Sandostatin, Octreotide, to treat patients who have Carcinoid syndrome, because it reduces the secretion of serotonin. But there's also another drug now, which is an oral agent that you can use if those don't work, is to try to inhibit this enzyme, the tryptophan hydroxylase, and therefore you have less production of serotonin. I do not know if this drug is available in the Middle East, but it's been approved by the United States FDA a few years ago, and we use it nowadays. So let me move on to the next slide here. So the carcinoid syndrome, how do we treat it? I saw a patient yesterday evening before I left the clinic. She was 70-year-old. She has a lot of diarrhea. How do you manage those? Obviously, you try antidiarrheal medications. We talked about somatostatin analogs, short-acting, long-acting. The short-acting is like giving the short-acting insulin if they have a lot of symptoms, because in the long-acting you get every 4 weeks. 4 weeks. There's another way of treating them, which is going to treating the liver or removing part of the liver, and I'll come back to this in a few minutes. So there are a number of ways that you can go around it. But when you have diarrhea in those patients, not all the diarrhea is caused by the carcinoid syndrome. Yes, carcinoid syndrome is a top cause for it, but it can be from bile salt diarrhea also. So when Dr. Schneber removes the terminal ileum, he resects it, he's removing the part where the bile salts are being reabsorbed. So that can cause bile salt diarrhea. Or if they take too much of the small bowel, you get short bowel syndrome. But also, as I mentioned to you, the somatostatin analogs, they also reduce they cause pancreatic insufficiency, steatorrhea. So all these things. So you have to be very careful and analyze the symptoms. And a lot of times we end up with trial and error. We try this, we try that, and see which one will work best for the patient, because a lot of times we can't even differentiate well, but you have to work on that. So this is the study that was done with the oral agent, which has a very difficult name called telotristat. The trade name is Zarmello. And in this trial, they showed that they can reduce the diarrhea of those patients. So this is something which you probably know. I really want to take a 30-second break and answer a question. So Dr. Mohammed Al-Sayed asks, is neuroendocrine tumor cancer hereditary? The short answer is mostly not, like most cancers, but pancreatic neuroendocrine tumors can be hereditary. And yes, the MEN1 syndrome we talked about, the VHL, neurofibromatosis, but the vast majority of the patients are really not going to be hereditary. But yes, it's a possibility. So the other thing which I wanted you to be aware of is, and I'm sure all of you have seen this, when you look at liver metastases in those patients. So one thing I told you, if you see somebody who comes to you with a lot of disease, they don't have much in their symptoms, you say, well, this doesn't look like adenocarcinoma. Someone has a primary tumor in the pancreas, has a lot of disease in the liver, but looks happy. This is not adenocarcinoma. This is neuroendocrine tumor. The other thing which can help you also is if they have opposite to what most adenocarcinomas are, pancreatic neuroendocrine tumors or small bowel neuroendocrine tumors, When they go to the liver, they are like this. They look hypervascular. Unlike if you look at the reports you get from, let's say, colon cancer or breast cancer or pancreatic cancer, the radiologist often tells you it's hypovascular. Here it's hypervascular. So another distinction. Another disease in the liver that can be hypervascular is obviously the hepatocellular cancer. Hepatoma is also hypervascular. So in those patients, what it tells you is that they like blood supply. So they enjoy angiogenesis. So they really like it. So one of the things we do, one of the treatments we do in some patients, again, depends on the patient, you do liver-directed therapy. How do you do it? You go through obviously the groin to the aorta, hepatic artery. And these tumors in the liver that are hypervascular, they take most of their blood supply from the hepatic artery. Unlike the normal liver, which takes more of its supply from the portal vein. And therefore, it makes sense. So if you give something like radioactive material, chemotherapy, directly into the liver, it will go more to the tumor cells than the normal cells. So that's a good thing. So you have less toxicity, but there's nothing free. Something always causes some degree of toxicity. So we use this. Now, if you have someone who's having a lot of carcinoid syndrome, you're trying octreotide, lanreotide, you're trying that oral pill that I told you about, the Zermelo, it's not working. Another way of really dealing with the Carcinoid syndrome is trying to start killing those cancer cells that are producing the serotonin. Obviously, that's not the only reason why we do liver-directed therapy. We also do it to control the disease as part of our treatments. As I said, if you have a good surgeon, a good hepatobiliary surgeon, someone has disease in the liver, debulking it is always should be at the back of your mind. You have to always think about it also. And if you do liver-directed therapy, the one I told you about, it can give you a really very good response. This is a patient who had pancreatic neuroendocrine tumor. We did liver-directed therapy. The CAT scan looks like this: big liver, many lesions. Now it's smaller, and his chromogranin A in the blood just plummeted. So you can do that. However, we like to be now more scientific. And one of the things we also like to do is start to think of molecular profiling as we work out these patients. And this is an algorithm. I'm not showing it to you for the details as much as I'm showing it to you that we do these things for us to help us to really decide, are they poorly differentiated, well differentiated, as I showed you earlier, but also some of these molecular markers like like loss of RB, makes the tumor, the predictive value of it is that it can be more sensitive to platinum compounds. And again, for the sake of time, I'm really not going to expand too much. So just trying to finish off, something which is really very important for me is that this is a type of tumor that requires a multidisciplinary team. And I think there's an opportunity for you in the Middle East, maybe you already have it, to establish a clinic which is more like regional or central clinic where there will be specialists and patients coming to it, because it does not make sense for these patients to really be treated by an oncologist or somebody who treats one a year. You need someone who treats 50 a year or 40 a year or 30 a year. And the only way you can do it is that you have a regional center for that. And to me, that's very important, because I see patients who are mismanaged even where I live in the United States, because people try to treat them, but they don't have enough knowledge and experience. And you need a lot of people here. So if you're trying to establish something like that, so you need a medical oncologist, you need a surgeon, nuclear medicine, diagnostic and interventional radiology, pathologist, gastroenterologist, cardiologist, radiation oncologist, and of course, endocrinologist. So this is really very important. And I think this is something which you can develop in the region if you don't have it. And I'm sure you have it by now. And just to go over so how do we really overall put this thing together? So how do we manage patients? What does it depend on? The stage, the grade of the tumor, as we talked about, the tumor burden, symptoms. But every patient, the goals are different maybe, but it should be highly personalized. And this is something which is very, very unique for these tumors, because every patient is different we know that. But not only every patient is different, but every patient's needs are different. But at the same time, patients have different things that we have to really focus on. So this is really very important. And this is just a reiteration of what we're talking about. Again, the factors that we're dealing with and all that. And again, the goal of the treatment is someone who's really going to live a long time. You just want them to have a good quality of life. So the way you bring and sequence these treatments is very much required to do personalized. And it takes time, and you have to spend time with the patient, but you have to have a nice team. I think you can establish those teams. It makes sense for you to do it well, and not send those patients. You don't have to send them elsewhere to be treated. This is just the conclusions, and just a repetition of what I said. Again, long natural history. There are a number of drugs we talked about, somatostatin analogs, newer treatment as encouraging, which is the PRRT, and then we're coming into the molecular era with becoming more personalized in our treatments, and finally to stress the point about having a good multidisciplinary team with expertise. And with that, I think this is my last slide. Well, I thank you again for your attention, and I'm really privileged to do it, and I'm open to any questions you have, or if you want to email me or anything like that. Thank you.
Thank you, Professor Philippe, for your elegant presentation. And I think we have to take advantage of having you with us today and ask you many questions I have in the chat box. For metastatic pancreatic neuroendocrine tumors to liver with multiple liver metastases, which type of surgery might be considered? Yes.
Well, it will be certainly a surgery that that will remove as much as possible from the tumor from the liver. So again, it has to be in a way that can be done, and again, it's a debulking. You cannot remove the whole liver, but if you remove most of the liver, leaving 20% behind or 30%, depending on the health of the patient, of course, that's what we're looking at. Something which I really did not include here is the issue of the liver transplantation. So liver transplantation is considered in some places. Obviously, after also you remove the primary tumor in the pancreas or in the small bowel. It's not routine in the United States, but it's done. And it's done very, very infrequently. Very few cases happen per year. As you know, Steve Jobs is one of the people who had a liver transplant. So the surgery, there's nothing special about it except for the surgeon being able to remove almost most of it, even if they leave something behind, because the liver will regenerate. Now, you wouldn't say the same thing for someone who has pancreatic cancer, adenocarcinoma going to the liver, because the life expectancy is much shorter. It's like 6 months to 12 months. Here, you're talking about many years life expectancy. So you see the difference. It's a different situation.
Okay, thank you, Professor Philippe. We have another question from Professor Ahmed Gaballah. Thank you for the elegant presentation. Nowadays, we see some cases with low or intermediate grade neuroendocrine tumors, Ki-67 less than 20%, but with a strange and aggressive behavior with rapid progression and development of metastasis. Can we manage them as high grade with chemotherapy, or still there is chance for other targeted agents? My second question about the high grade, well-differentiated tumors, Ki-67 between 20 and 40% or even 50%, they are not responders for targeted therapy and poor responders for chemotherapy. What do you think the best strategy for management?
So one thing which, again, for the sake of time, I left out was, so let me go back to the issue of the Ki-67. When I see a patient, new patient with my fellows, trainees, or residents, I tell them that the pathology can help me, Ki-67 can help me, but the thing which helps me most in knowing the patient is the time. Over 6 months, 1 year, how their disease is going to develop. Because you're absolutely right. And the patient who I saw last night, her Ki-67 was low grade, actually. but her disease is progressing fast. So it can't be right. So there's something else. So how do you make the difference? Either the original Cas7 was wrong, or the patient has different clones of the disease, and I'll come back to that. So in some cases, we have been rebiopsying the patients, and when we rebiopsy, we see a different result, a higher Cas7 in patients who we suspect that they're not behaving the way we expect them to be. Now, hopefully, the next step will be for us to use molecular profiling to really add to the Cas7 to see where the patient falls. And that's why I was trying to tell you that we're doing that. Now, in terms of treatment, in patients who come to me and there are symptoms, they have burden of disease, and they are intermediate grade. I don't do it maybe in grade 1, but intermediate grade. There are patients who I start them on chemotherapy straight away. To me, I don't think they will respond to somatostatin analogs. So for the chemotherapy, the preferred regimen we use is capecitabine and temozolomide. This is our America preferred regimen, both oral pills. And I would start with the capecitabine and temozolomide in someone who really is an intermediate grade with symptoms and something which is going fast. If the capecitabine and temozolomide does not work, it would be an option to do another chemotherapy regimen. In this case, we use carboplatin etoposide. In patients who come to us with Cas67 of more than 20%, if they are reading as more well-differentiated tumors, we also start with capecitabine temozolomide. If they are poorly differentiated, then certainly we don't do capecitabine temozolomide. We go straight to etoposide and carboplatin. There's no real good answer here. It's a matter of just using cytotoxic therapy in patients who are rapidly progressing. And that's what we do. People in Europe still use streptozocin-based treatment. We rarely do that in the United States. In patients who have rapidly growing disease, my experience has been that really they don't respond to PRRT or Lutathera, so we don't use that. And also they don't respond to everolimus, and they represent a problem for us. If it's rapidly growing in the liver mainly, then we can use liver-directed therapy, but certainly systemic therapy is our first option.
Okay. Professor Marwa Abdelgawad, you have a live question. Professor Marwa? Okay. Professor Marwa Abdelgawad is asking, is there any role for Octreotide or mTOR inhibitors in neoadjuvant treatment?
Dr. Muhammad, yes.
Yes, Professor. Yes, Dr. Marwa?
Yeah.
Yes.
Thank you for these nice presentations. It's really good. Nowadays, neuroendocrine tumors is exceeding far, that the cases are more far than expected, especially the pancreatic cancer. And it occurs in young age. This is unfortunately in the 50s and the 40s. So my question now, what about the neoadjuvant mTOR inhibitors or hormonal treatment in the cases of the pancreatic neuroendocrine tumors grade 1 and 2?
So neoadjuvant treatment, Marwa, as you know, it's used to, most of the time we use in, rectal, breast, others, is to shrink the tumor down. However, these drugs like the somatostatin analogs or the Afinitor, they cannot shrink the tumor down. So in patients who have grade 1, we don't use it to do that. If you have someone with grade 2 or above, maybe, and it's a big tumor, you want to help the surgeon shrink it down, I think there is room for using chemotherapy, but I wouldn't use everolimus or lanreotide or octreotide as a neoadjuvant treatment. In fact, we never use that.
Okay.
Does that answer your question?
Marwa, are you okay?
Yes, thank you. So, also, there is no rule for the new adjuvant chemotherapy in the patients are panic. Are some patients, especially the Egyptian patients, are panic from the surgery, from the start in the pancreatic cancer. So, there are any data or any trials for the new adjuvant chemotherapy in the large tumors, grade 1 and 2?
No.
No.
The only trial we're starting within the next few months is in the adjuvant in higher risk pancreatic neuroendocrine tumors who undergo surgery. In those patients, we will be doing capecitabine temozolomide versus placebo or observation, but that's only an adjuvant.
Okay.
Thank you,
Okay,
Marwa.
thank you.
Professor Philippe, I have multiple questions for you, and I want to take advantage, as I told you before, in your experts in the microenvironment and molecular biology. First of all, I have seen yesterday positive results for a drug called surufatinib in the SANET trial for pancreatic neuroendocrine tumors, well differentiated, who originate from outside. So my question, what is the difference between originating from outside and the inside as regarding behavior and molecular characteristics, and why this study was done for pancreatic well-differentiated tumors who originate from inside, and the drug surufatinib, as we all know, acts as fibroblast growth factor receptor inhibitor and VEGF inhibitor, and also what is very interesting is the CSF1R inhibition, which can modulate the microenvironment or the immune microenvironment. So what is your insight about the SANET trial and the new drug surufatinib with overall response rate of around 19%?
Yeah, so this is a Chinese drug.
Yes. This is a Chinese trial. Yes.
Yeah, we're not working on it in the United States as yet. I think there is talk that we might be doing some studies. I cannot answer the question about what you mean by from inside or outside. So
yes, I saw it in the inclusion criteria. So what is inside and outside? What's the difference?
Yeah, what I will do is I'll check it out and I'll respond to you personally.
Okay. Another question is as regarding immunotherapy. As we all know, neuroendocrine tumors are thought to be cold tumors because low infiltrating lymphocytes, low tumor mutational burden, and low PDL expression. So I think we have to do our clinical trials based on combination trials to overcome the mechanism of resistance. So a single agent immunotherapy or combination of PD-1, PD-L1, and CTL4, like the June trial of durvalumab and tremelimumab. I think this will not overcome the problem of resistance of the microenvironment of neuroendocrine tumor. Yeah. Although we have a positive signal with Nivo plus Epi around overall response rate around 44% for high-grade tumors, not low, not G1 or G2, only for high-grade tumors. So do you think we have to do a combination between immunotherapy and VEGF inhibitors and other modulators instead of going on single agents PD-L1?
Yeah, so basically, again, thank you for the question. So when you look at, I just want to take it a bit further back. So if you look at the molecular mutations in patients with neuroendocrine tumors, the most boring ones are the small bowel, for example. They're boring. There isn't much happening there. The one which is more interesting is the pancreatic neuroendocrine tumor, which has more mutations. But there's also evidence that the PD-L1 expression is, as the tumor becomes more higher grade, you see more PD-L1 expression. We don't see MSI high, very rare, very rare.
Yes.
And as you said, you rightly said. So at this point in time, the only study I'm aware of that produced some preliminary data is the one you mentioned, the DART trial, which was done by our colleagues at SWAG. I'm also from SWAG.
Yes.
Oncology group. So they did that study. And based on that trial, a colleague of mine, David Zhang, is starting a randomized phase 2 trial in high-grade tumors using carboetopicide plus minus atezo.
Yes, perfect.
Which it will be like small cell. But we don't think that in the low grade, intermediate grade, we will be ever able to really make immunotherapy work. So that takes me to the second issue, which is, can we add something else? Well, as you know, throughout the world, we're combining immunotherapy with other drugs, like you heard about Ipi/Nivo, you heard about IO plus cabozantinib, you heard about atezolizumab for HCC. In my personal opinion, that's not going to really work for neuroendocrine tumors. And the only area that it may have something will be in the higher grade tumors. But the higher grade tumors are so aggressive that sometimes you can't catch up with immunotherapy. I mean, they need something to kill the cancer cells. So as much as I would like to believe that we can improve immunotherapy with additional drugs, I really do not think it's going to happen anytime in the next 5-10 years in the neuroendocrine tumors. I don't think so. I'm sorry, I can't give you another.
Yes. Another question. I know you are an expert in the development of drugs. So if we go back to the Radian 1, 2, and 3, and 4 trials, the Radian 1 was a positive trial for, although it is a phase 2, for combining octreotide and everolimus. But when we moved to Radian 2 and combined octreotide and everolimus, this was so far a negative trial. Although we know that octreotide down-regulates insulin growth factor 1, which is an upstream activator of AKT and mTOR. So it is a proof of concept of combining octreotide and everolimus in pancreatic tumors. So we have reserved only everolimus for pancreatic neuroendocrine tumors and other GI and lung tumors. And we didn't combine them again after the failure of Radian 2 trial. Although I think it is a proof of concept of combining both of them.
Yeah, I know. I mean, unfortunately, it's something which no one is going to go back and do it.
Yes.
And I'll tell you why. Because, again, I don't know about your area, but in our place, usually everolimus comes after octreotide.
Yes.
Right? Same thing with you, right?
Yes, yes.
But in America, they keep them on octreotide.
Okay.
I mean, they stay on octreotide. So no one's going to do a clinical trial to see if is both better than one or something like that, because it requires a lot. It's a big clinical trial, and no one is going to do that. But I see your point. But in practice, we are keeping them on octreotide, so they're getting the two drugs. Were you thinking of doing a study or something?
No, I'm just asking because I saw the molecular pathway and I saw that it was positive in the Radian 1 trial, and the results was good. And then I know we have used Radian 2 trial was with mid-gut functioning tumor, and as we all know, everolimus doesn't work with functioning tumors and works better with non-functioning high-grade tumors.
Yeah.
Yes. Another important issue. A few days ago, there was the results of the CLARINET 4th trial of lanreotide autogel, 120 milligram. So in pancreatic neuroendocrine tumors, they have sought at toxicity and safety of using lanreotide every 2 weeks on progression instead of 28 days. So what's your insight? And I think it is a good point of view to not to switch to another drug until you can give this drug in a less frequency than before. Yes.
Yeah. So I saw that study abstract. It's not published yet. I saw it in the ESMO meeting. Yes. And in fact, soon after I saw it, I had a patient who was newly diagnosed, but her disease was intermediate grade, and she had symptoms. And I said to her, I'm going to use it every 2 weeks. Now, in the United States, we have a problem with the insurance people. They may not agree, but in this case, they agreed because it's expensive. So they want to make it like every 2 weeks becomes doubling the cost. Yeah. But actually, they agreed, and I did a scan after 3-4 months, and she's stable. So I think there is, in my opinion, I agree with you. I mean, some patients either progression on lanreotide or they come to you with disease that it doesn't look that good, but you don't want to go into everolimus or something else, you can use every 2 weeks. Yes.
Okay.
I think the data to me looked, I mean, it's hard to say convincing because we don't have the full publication, but it looked to me interesting enough for me to use it. I agree.
Yes, and I think the safety is the most important issue.
Yeah.
It is safe, yes. We have many other questions. Professor is saying, is embolization versus debulking versus systemic therapy? How do you choose? He's asking, as regarding embolization versus debulking versus systemic therapy, how to choose? Selection criteria. Yes.
So basically, if we have a patient, we start with the patient. If we have a patient who is otherwise healthy, a patient who is healthy and doesn't have much in the way of extrahepatic disease, like they don't have bone metastases, and which can happen, as you know, in neuroendocrine tumors. In those patients, and the disease in the liver is not too extensive for surgery to be almost impossible, we do start either with doing a liver direct. If we're trying to debulk, we start with either giving a initial radioembolization to shrink it down and surgery, or go to surgery right away. In my opinion, in someone whose disease is grade 1, especially, otherwise healthy, otherwise young, otherwise resectable in the liver, we will go for resection. Our second option will be the use of radioembolization, or use radioembolization to shrink it down and go for resection. The systemic treatment, we use it more for patients who we don't think surgery is really a good option. They're not good candidates for surgery. In that case, we will go for, in fact, even when we do the resection, we probably end up putting them on lanreotide, because normally resection is not going to be like curing them. So we still put them on something after the surgery. That would be pretty much what I would say. I mean, I would say I would start with surgery. Can I do it? The patient is well enough for it. If I can do it, I can do it right away, or give some radioembolization to shrink it down a bit and then do it. And then that would be my thought. But it depends on the patient, how well they are, age, comorbidities, willingness to go through a major operation, and all these things.
Okay, we have another question from Dr. Radwa Sabra. I think she's asking about manic and menin. She's asking how to treat GIT adenocarcinoma with neuroendocrine differentiation. How do you treat patients with mixed neuroendocrine and non-neuroendocrine adenocarcinoma? Menin.
So for us, we look at, we review them in the pathology, in the tumor board. And if the pathologist tells me that this is mainly an adenocarcinoma with neuroendocrine differentiation, those patients, we treat them as adenocarcinoma.
Yes. Okay.
How do you do it? How do you do it there?
The same. I will treat it like an adenocarcinoma with FOLFOX and FOLFIRI regimen as GIT adenocarcinoma. Yes.
So and then in those patients, some of them, I have a patient who also had BRAF mutation, so you end up with some. And then the second line, I went to BRAF,
anti-BRAF, yes.
BRAF treatment.
Yes. Another question from Dr. Radwa is asking, is there a role for anti-angiogenic agents in the future, anti-VEGF agents in neuroendocrine tumors?
Okay. I personally think that, now remember, some of the drugs like you mentioned, the surafatinib, like sunitinib, they have anti-VEGFR activity.
Yes.
The bevacizumab trial that was done a while back, it was done, I don't think it was done in I don't think the trials so far in the anti-angiogenesis were done in the best way, or they were conclusive, if that's the word. So I personally think that there is room for further work on the anti-angiogenesis, yes. But it might be the combination. I think that would be the key thing. So yes, in my opinion, the disease, there's no doubt that not all patients, but a fair number of patients do have, from the scans, even looking at the scans, there is a lot of angiogenic activity. So I would be surprised if there's no room in future, but it has to be the right drug and the right clinical trial.
Okay. There's another question, Professor Bassem al-Bahrani. Any role for alpha-targeted therapy like actinium-225 in the treatment of metastatic neuroendocrine tumors?
Which one? 125? Which one?
He's saying alpha-targeted therapy like actinium-225, something like that.
Okay, so is that, I think you're thinking of PRRT, right? Yeah. I don't know. I know maybe there's some work. Yes. There's some work being done in the United States, but I can't comment where they stand.
Okay, another question for Professor Ahmed Hamid. How frequent radioembolization should be done? Is it a one-time treatment or it is possible to be repeated?
It can be repeated. Yeah.
Okay. Yes. And Professor Ahmed Gabala is asking what.
Now, can I make a comment here?
Yes, yes, yes.
So basically, people think of radioembolization as being benign. It's not benign. You can repeat it, yes, but it's not. It can have its long-term complications. And in the United States, we are divided in our thoughts about radioembolization with downstream PRRT. There are people who believe, especially people in the University of Pennsylvania, they believe that doing radioembolization, and if you do later PRRT, you might increase the toxicity on the liver. Just something to keep in mind.
Yes.
But at this point in time, there is no published or definite evidence for or against that thought. So if you're going to plan on PRRT for some patients, I think you just have to be a bit cautious. In fact, some of the people they say any liver-directed therapy, like any hepatic artery-directed therapy, is not good. Again, I don't have an opinion because I don't think anyone knows. Some people might just use anecdotes. But back to your question, radioembolization can be repeated, yes.
Okay. And Professor Ahmed Gabala is asking, what do you think, sir, about role of HIFO for locally advanced disease to decrease the symptoms? Do you have any experience with HIFO?
Role of what, sorry?
HIFO, high intensity, it's something like radio frequency, invented by the Chinese also, HIFO.
Yeah, I don't know if it's RF radio, it's not radio frequency ablation, right?
Yes, it's high intensity modulation, yes. Okay. Okay. For me, I'm asking you a question about philosophy. What do you think about the neuroendocrine paradox? How a low-grade tumor G1 and G2, well differentiated, when diagnosed, can have a large size and metastasis to another part than the original area. This is a paradox, a low-grade tumor, and heavily metastatic and can reach a big size.
We call it the inverted pyramid.
Okay.
Inverted pyramid, like the primary is narrow, but metastases are a lot.
Yes.
So that's the biology, and that's what we call it, inverted pyramid. No one, I don't think anyone knows about the biology, why it happens. But you're right. You can have a small lesion tumor in the terminal ileum with many more liver metastases, and the primary is even sometimes you can't see it. I don't know why that is. I mean, obviously it takes many years for it to develop, but I wish I can give you a better answer.
Yes, the same question is as regarding the vascular paradox, as we have seen from neuroendocrine tumors, and you have mentioned. The most vascular tumors are the most differentiated and the least aggressive and also the least angiogenic. So how come it is also called vascular paradox, yes?
Yeah, it is. I mean, I know. And I I mean, I don't want to really dodge the question, but unfortunately, the basic science is a bit behind, very much behind. You know why? Because we don't have tumor models, good tumor models.
Yes. Yeah.
And one thing I didn't mention is the use of FDG PET. I didn't go into that because that goes into also the aggressiveness radiologically. Because if you do FDG PET and also you do a dotatate and you get the results, that can tell you how aggressive the tumor is because there is this inverse relationship between the two. And that's one way nowadays people are looking at, there's algorithm, but I cannot do both of them because the insurance company will not allow me to do 2 PET scans in one patient. Do you do that? Do you do FDG and dotatate together? Or?
Yes, we have it recently here in Egypt. Yes. Not together.
No, not together.
Another question.
Not together at the same time, but
like sequential. Yes. Another question: how do you choose between from one of our colleagues? How do you choose between octreotide and lanreotide? What's your preference, and according to what? How do you select between both of them?
So basically, in my opinion, they are both. They both work the same. Lanreotide is a bit easier for the patient, deep subcutaneous versus IM. So that might be one differentiation. The second thing is that if you say I want data, then lanreotide was done in patients with pancreatic neuroendocrine tumors, whereas octreotide was only in small bowel. Lanreotide included patients with intermediate grade up to 10, included intermediate grade of 10%, whereas octreotide did not. But the bottom line is that lanreotide was done by a drug company, a sponsor study. Octreotide was not done by that, so the studies were different. Octreotide LAR is not really in America approved even for the indication that we use it for. So I don't think there is a difference. One thing with octreotide is flexibility with the dosing. Like you can do 10, 20, 30, 40, 60, whatever. With lanreotide, you cannot do that. So, but again, these are not major differences. For me, they don't really come to me as different.
Okay, a very important question to end about our session today. As you have said before, around 30% of patients are diagnosed after 5 years, and I think 50% or after 2 years. So how can we work together or collaborate? What is the best algorithm for an excellent expertise center to manage neuroendocrine tumors? We want to diagnose early. We want to give an advice for our junior junior doctors and for us as seniors, how to proceed, how to diagnose early, what to do to diagnose neuroendocrine tumors early. I think we want your advice.
Well, that's a tough one because in the States we can't do it. We're having a struggling within the States. The problem is that it's not a matter for the cancer centers because patients don't come. I mean, they're seen by the primary care providers. They're seen by gastroenterologists and endocrinologists. These are the 3 main people they see. They don't see me. I mean, they come to see me when someone says you have carcinoid and they do it Chromogranin A, they come to me. But that's not what I want to see. I want to see someone who, I think it really goes down to GI and primary care because patients who you look at, so if you look at and see patients who really are most misdiagnosed are the ones who have the irritable bowel syndrome or even inflammatory bowel disease diagnosis. These are the most commonly missed patients. And gastroenterologists' problem is that they only do endoscopy and they're out. I don't think they spend enough time to talk to the patient and follow up on the patient. And that's really my problem. I think there should be someone we have to sit there and see what are the symptoms and algorithm based on symptoms. And I think partly if you get artificial intelligence, they will help you with this. because there will be symptoms that are typical of carcinoid. They're not typical of irritable bowel syndrome, but yet people go to the doctor, and each time they go, they treat them as irritable bowel syndrome. And the same thing with flushing, for example. They are to, but the most important thing is really diarrhea, abdominal discomfort, and the misdiagnosis of it. If you can handle that, you're going to bring more patients earlier on to the diagnosis. And but then you ask the question. If you diagnosed it earlier, would you be changing the natural history of the disease? That's the other thing. So I had a patient who came to me. He was, he's still my patient. He's in his late 50s. So he came to me with multiple liver metastases, biopsy, low-grade neuroendocrine tumor. And then we asked him to get some scans, get some old scans he had some other time. 9 years ago, he had a CAT scan for something else, and he had 2 lesions in the liver. They didn't tell him about it. I don't know why. 2 lesions in the liver. Now he comes to me with more lesions in the liver. But do you think this guy would have done better if it was diagnosed 9 years ago or even 15 years ago? And that's the question. I don't know. I'm not sure if we really
تحياتي من عمان دكتور فيليب، كل الزملاء، كل الأخوان الحاضرين. أنا الدكتور سامي الخطيب. We are close friend مع دكتور فيليب. He is the closest friend of our area ودائما هو جاهز. Just حبيت أمسي عليكم وأحكي لك thank you for the excellent lecture. وأضيف على آخر سؤال ضافه بروفيسور محمد إنه I think إنه the best way إنه نعمل special registry في الاريا تبعتنا للنيورو-اندوكراين diseases. فبالتالي هذا بيخلينا نتمكن نعرف إيش الأعداد المتواجدة عندنا في الوطن العربي، وبالتالي وضع البرامج اللازمة للكشف المبكر عليها.
I think so, yeah. I agree. I mean, that's يعني أشكرك سامي كالعادة. Thank you very much for your kind words. I think this program was forget about my talk, Sami, but I think and Professor Mohammed, but I think the discussion is one of the highest you can ever get. So it tells you one thing, that you have the right people. So you really have to get together. I hope you agree with that.
Yes, I agree. وإن شاء الله إنه من خلال ممكن إنه من خلالنا كرابطة الأطباء العرب لمكافحة السرطان إنه نبدأ نعمل هيك registry. وأنا I think إنه الشغلة is feasible و not costable at all.
I think so. I mean, I think there's a lot of opportunity there. I mean, again, the discussion today is really tells you that people are on board, or you just have to get things moving.
Yes, thank you, Professor Sami, for your insights as usual. Thank you. We have another question, Professor Hussein Miki from Khartoum Oncology Specialized Center. He's asking about prostatic neuroendocrine tumors. As we all know, we found some cases with prostatic neuroendocrine tumors, especially in the metastatic castrate-resistant area after androgen receptor treatment. So how do you see these patients? How do you see them? How do you manage prostatic neuroendocrine tumors? Do you rebiopsy? What do you do?
They don't come to me. They go to GU.
Yes. Yeah. So if they have been found by GU, as we all know, the new guidelines of metastatic castrate-resistant prostate cancer is to rebiopsy, because around 40% of patients develop neuroendocrine differentiation. So if they diagnosed by GU, do they come back to again to you, Professor Philippe, or managed by them?
Managed by them, yeah.
So we don't put them in the data of neuroendocrine tumors. So we don't count them.
Well, I mean, my focus is on GI. So, and I don't think they really. No, the short answer is they don't get into the neuroendocrine. No.
Okay. So we don't count them as a number of neuroendocrine cases. So
no.
What do you think? Yes.
They count part of prostate.
Okay. They belong to prostate, not to neuroendocrine.
No.
But they are managed as high-grade small cell neuroendocrine tumors, or
they're managed as small cell.
yes.
It's like the small cell lung cancer. We don't put them as part of the same thing.
Tripocyte cisplatin, yes, yes. Do we have another question? I think we have exhausted you, Professor Philippe, today, but we have to take the chance to have you with us today. For me, it is a big chance to have you and to discuss with you, and all my colleagues are happy to have you with us, Professor Philippe. You are a great friend and a great scientist, as we all know. Thank you, Professor Philippe, and I leave the floor for Ahmed Ali to yes, Professor Ahmed.
Just to say, Professor Philip is going to be with us في المؤتمر البان عرب اللي رايح ينعقد إن شاء الله في عمان فيرتشوال. فدكتور فيليب راح يشرفنا.
Perfect. Thank you, Professor Sami. Yes. Professor Ahmed.
Yes. منور دكتور سامي. منورنا يا فندم. Thank you, Dr. Philip, for your excellent presentation. Thank you, Dr. Yassin, for your effort and great discussion. Thank you for all attendees on behalf of EMOG group. We are all thank you, and we hope that you are enjoying for this scientific meeting. And I remind you again, our next event will be in the neoadjuvant breast cancer with our colleague from Canada in the Friday after next, 18 December, sorry, after 2 weeks. We hoping to see you again in this meeting. Thank you for your effort. Thank you.
Thank you, Professor Philippe. It was a great honor for me. Thank you, Professor Philippe.
Thank you. I hope everything will be safe and you'll be well in the region.
Thank you.
Thank you. Thank you. Bye-bye. Thank you, Professor Sami. Thank you.
شكرا.